How does palliative care differ from physician-assisted suicide? Imagine facing a serious illness and wondering what options are available as you approach the end of life. Two choices often come up in these conversations: palliative care and physician-assisted suicide. They might seem similar at first glance, but they are actually very different in purpose and ethics. Palliative care is all about making patients comfortable. It focuses on relieving pain and other distressing symptoms without trying to end life early. The goal is to improve quality of life by managing physical pain, emotional struggles, and spiritual concerns. For example, doctors might prescribe opioids to ease severe pain, but the main aim is comfort, not to cause death. Even if a medication might slightly shorten life, the intent is to help the patient feel better, not to hasten death. This approach follows the ethical principle called the double effect, which allows actions that have both good and potentially harmful effects if the good is the primary goal. Physician-assisted suicide is quite different. It involves a doctor providing a patient with the means, usually a prescription for a lethal dose of medication, so the patient can end their own life. The key point is that in physician-assisted suicide, the patient intentionally causes their own death. This practice raises ethical questions because it involves actively causing death, which conflicts with the traditional medical role of saving lives and doing no harm. Many medical organizations oppose physician-assisted suicide because it can damage trust between doctors and patients and challenge the idea that doctors are healers. Looking at the core medical ethics principles, both practices involve respecting what patients want. But palliative care supports patient choices by easing suffering and helping them live as comfortably as possible. Physician-assisted suicide, on the other hand, involves helping patients end their lives, which sparks debates about how for patient autonomy should go. Palliative care embodies beneficence, which means acting in the patient's best interest, and non-maleficence, which means avoiding harm. It aims to relieving suffering without causing death. Physician-assisted suicide challenges these principles because it involves intentionally causing death, which some see as a form of harm. Justice is also important. Ensuring everyone has access to good palliative care is a matter of fairness. Ethical concerns about physician-assisted suicide include the risk of pressuring vulnerable groups and normalizing death as a quick solution. Practically, palliative care involves a team of healthcare providers offering symptom management, emotional support, and planning for the end of life. It aims to keep patients dignified and comfortable until natural death occurs. When physician-assisted suicide is legal, it is carefully regulated. It is only available to mentally competent patients with a prognosis of 6 months or less, and the patient must self-administer the medication. In summary, palliative care and physician-assisted suicide are fundamentally different. Palliative care seeks to ease suffering without intending death, supporting the healing role of medicine. Physician-assisted suicide, when legal, involves intentionally ending life, which raises complex ethical questions about the role of doctors and the value of life itself.